At a time of year when everyone's you know what we need is
just hold up.
Good morning. Welcome to the first grand rounds of the Department of Medicine of 2015. Dr. Boley just reminded me that we need a raise for everyone who made it here today at 0 degrees. Thank you. For that, everybody raised their hand. I see that. Thank you. So before we start, a few comments. I think I'm a little too loud. Today was the birth of the king. Elvis Presley was born on this day back in 1935, but it was also the birth of another king, Stephen W. Paul King, who's an English theoretical physicist. You may remember him from the book A Brief History of Time. You may remember him as the person who holds the Lucasian Professor of Mathematics at Cambridge University. His work in theoretical cosmology and quantum gravity. I recommend you watch the movie A Theory of Everything. And if you don't have time for that, just get the 6th season of Star Trek and watch how Data creates a holodeck with Einstein, Hawkins, and Isaac Newton, because you want to see how they interacted in a game of poker. Hawkins is believed to be the only actual person who has played himself in Star Trek. Enough of trivia. In 1998, on this week, Nature published an article about nicotine and its function. Pasteur Institute and Karolinska Institute in Stockholm, Pasteur Institute in Paris and Glasgow came together to understand how nicotine-induced dopamine and induced addiction in the brain, and actually identify the nicotine receptors responsible for this, and found that a beta-2 nicotinic receptor was responsible for the effect of nicotine because it didn't happen in mice who didn't have this receptor, and that created the foundation for the drug varenicline or Chantix, which is now used today for the treatment of smoking cessation. But today is about the heart and cardiac arrest, and I want to remind you that Archer Gordon, I don't want to steal your thunder or anything, but was born on this day in 1941. He was an American physician who contributed greatly to the acceptance of CPR. In 1949 to 50, he evaluated the several methods of artificial ventilation and compression, and he found that they worked, but they were of marginal benefit. A couple of years later, James Elam reported a first published paper where he can actually introduce air into the lung of a non-breathing human being through a tube. And then in the same year, Peter Safar demonstrated he can do that by just putting the mouth on top of the other mouth and showing that he can produce a change in breath by exhaling. And then, of course, USC reported the same in children. All in a period of a year or two, they changed the way we thought about CPR and artificial breathing methods. And with that, I'll leave you with Dr. Roberto Boley, Chief of Cardiology, who's going to introduce our speaker of the day.
Thank you, Jesse, and thank you all for braving this brutal cold spell and coming here this morning. So I'm delighted to introduce our speaker, Dr. Lorrel Brown. She's one of the new additions to our family. She joined us in July of 2014. Lorrel graduated from Hopkins in 2007, and during her medical school, she distinguished herself with a number of recognitions. She was the Sabin College most outstanding graduate, and she was selected as the student convocation speaker in 2007. She then went on to do residency in internal medicine at Hopkins and a cardiology fellowship at Hopkins. during which she also took a day off to be Assistant Chief of Service on the Austrian Medical Service at Hopkins, where she served as a co-chief president and instructor of medicine. And we were very fortunate to recruit her last summer here in Louisville. So Lorrel has demonstrated a very keen interest in education of residents and students, as well as in intensive care and coronary care unit activities. She has served on a bewildering array of committees during her residence, including the Intern Selection Committee, the Cardiology Service Operations Committee, the ED to Cardiology Service Admissions Guideline Committee, the Resident Teacher Task Force, the Medical Triage Officer Quality Improvement Committee, and the Education Policies and Curriculum Committee at Hopkins. And remarkably, she was a member of the Trainee Dismissal Grievance Committee. That really is quite admirable. I don't know how you did it, but it was quite unique. So she is full of energy, of enthusiasm. She's an outstanding young cardiologist. She will play an important role in the coronary care unit at Jewish Hospital and at University Hospital. She's also the Assistant Director of the Cardiology Fellowship Program. So we are sure she will be a tremendous addition to our program, and she will contribute to her department. We look forward to it.
Good morning. So yeah, I like to be on committees. That's, I guess, the summary of that. Today I'm delighted to talk with you about a subject that is near and dear to my heart. Can you all hear me okay? Great. I've never been told that I'm too quiet. So I want to talk to you today about in-hospital cardiac arrest. The facts or the data, dispel some of the fiction, and tell you a little bit about where the future of this relatively young field of science is going. I have nothing to disclose. At the end of this lecture today, my hope is that you'll be able to understand a bit about the epidemiology of in-hospital arrest so that we can describe both the incidence and the survival nationally and locally. That you can distinguish between which parts of the ACLS algorithm are evidence-based and which are not evidence-based. And Dr. Roman, you did not steal my thunder, but you might not be happy about what I have to say about respirations during CPR. And then next, I'll talk a little bit about the trainee experience in the modern era of duty hours with in-hospital arrest. And then finally, a little bit about where the future is going. And really, this field currently is focusing a lot on process, quality improvement, and application of what we already know to be true. So first, let's talk a little bit about epidemiology. However, I've heard that Dr. Roman requests to include basic science in our talk. So this is my basic science slide. These are cardiac myocytes, and they're dead. That would be a bad outcome after cardiac arrest. That's my only basic science today. Okay. I told you I have no disclosures, but I do have a confession to make. I learned everything that I know about medicine from watching the hit television drama ER, which had its final season in my second year of medical school. So every Thursday, my friends and I would put down the books and we'd go learn the real stuff by watching ER. And we'd watch and ask each other things like, do you think that's really what happens? Or is that really a thing, what they just said? Or every once in a while, someone would get snarky and say, I think they intubated that person upside down. So I first learned about in-hospital cardiac arrest from watching ER. And if you watch ER, what you learn is that if you arrest in the hospital, George Clooney will come and save your life about 90% of the time. I know that number because someone actually published a study looking at survival from in-hospital arrest on TV. But what you and I both know is that that's not true. George Clooney never shows up to any of the codes that I run. So how often do people code in the hospital? Well, I think you might be surprised by this. A lot of emphasis, attention, and effort has been put into the out-of-hospital arrest world. And if we look at the estimated incidence, which is a little challenging, the estimated incidence is between 200,000 and 300,000 per year in the U.S. If you look at the incidence of in-hospital arrest, about the same, 200,000 per year. So this happens with almost equal frequency on the inpatient basis. We know that survival for out-of-hospital arrest is abysmal, about 8%. It's also abysmal for in-hospital arrest, about 20%. However, we have been getting better over time. This data and much of what I'll show you today comes from a registry called the Guidelines Resuscitation Registry. This is a national registry of around 450 hospitals. They have cumulative over at least these 10 years that are reported, over 150,000 cardiac arrests. So a lot of our epidemiology comes from that registry. So if you look at the trends in survival from 2000 to 2009, we started doing a lot better. We increased from 13% survival to 22%. Before you start to pat yourself on the back, I should tell you that in 2005, survival was 20%. So we really haven't done very much over the last decade to improve this survival. This is what's been reported most recently. The data for sort of the last 5 years hasn't really been reported on in the literature yet. We don't just care about people surviving, though. We really care about what state their brain is in. We have started to do better with that. So if this is a clinically significant disability at the time of discharge, we've actually improved to some extent from 32 to 28, but not very great. And severe disability still remains high at about 10% of those who actually survive. What you may or may not know is that what rhythm you have at the beginning of your arrest greatly impacts your survival. VT and VF have a much higher survival rate in the modern era, about 35% or so, compared to asystole or PEA, which is around 10%. This makes some sense pathophysiologically because VT and VF often represent an acute or treatable or reversible cardiac cause like cardiac ischemia, maybe electrolyte imbalances and scar-mediated heat. So these things we can often do something about, aka shock you and then reperfuse you. Asystole and PEA are much harder to treat because they often are precipitated by an overwhelming systemic type of illness. And asystole, as I like to call it, is the lowest common denominator or the final common pathway for all parts. So if people start with asystole, you're basically starting already dead. Also interesting is what's happened to the relative balance of these rhythms over the course of time. Over the last 10 years in these studies from 2000 to 2009, we've seen asystole increase as the final or as the first presenting rhythm to approximately 82% of in-hospital codes start with asystole. So that is disappointing. Despite that, we're doing better. And you might say, well, why are we doing better? Is it just that everybody who's really sick is DNR, DNI, so we're only coding patients who actually would make it? This is looking at the trends in comorbidities for the patients at the time of arrest. And the overall trend is that, in general, there's a decrease in heart failure and MI, either a history of or during the current admission. So a decrease in really some of the reversible etiologies. And an overall increase in comorbidities and critical illness, including renal, hepatic, respiratory insufficiency, sepsis, trauma, and malignancy. So the patients, these are all statistically significant as well. The patients are sicker, and yet we've tended to do a little bit better when it comes to arrest. But there is a great variability in how hospitals perform and in the incidence of arrest between hospitals. This is a histogram looking at how many arrests there are per 1,000 admissions in hospitals in the U.S., and you see there's a pretty large distribution. The average is somewhere around 3 to 4 arrests per 1,000 admissions. But you see some outliers. These guys, please don't ever admit me to that hospital. That's about 18 arrests per 1,000. And I think these are the liars that say they only have 1 arrest per 1,000 admissions. But the point being that there's a really wide distribution of how many arrests a hospital experiences. And it turns out there's a pretty wide distribution in terms of survival. The time of the day that you code matters in terms of your outcome. This probably won't surprise you, but it hurts a little on the inside to see the data. So this looked at daytime hours, 7 a.m. to 11 p.m. versus nighttime hours, and it looked at all the days of the week. You can see that during the day, when lots of people are around, the cath lab is open, you have a lower nurse-to-patient ratio, survival is around that 20% mark. At nighttime, when the most senior physicians in-house are often trainees, and when we don't have as high ratio of staff to patients, survival goes down to 15%. And if you look at the weekend, where similarly people are less staffed, etc., the survival goes down and approaches those of the nighttime hours. I find this to be disturbing, but not all that surprising. If you look at how individual hospitals perform, so this is taking hospitals and putting them, ranking them basically, the lowest to the highest in terms of their median survival rate from in-hospital arrest. On the low end, you have as low as 8.3% in the unadjusted data, and the high end, 31%. Then if you adjust for all of the factors that we know influence survival from arrest, you still get a wide spread, 12.4% at the bottom, 22.7% at the top. Now, what about hospitals like us? You kind of want to know how we do. Well, in this study, they were able to separate the hospitals by type. So we're an academic hospital, survival median unadjusted around 18%, large bed size, urban, all around that 18% mark for survival. So that's what hospitals like us are doing. The interesting thing in this study is that the authors calculated a median odds ratio, basically trying to tell us how likely it is that you would have a different outcome if you were at a randomly selected hospital. And the way they put it is a little bit shocking. The hospital to which one is admitted may influence one's odds of survival by 42%. An enormous effect considering this is a hard clinical endpoint, and I would agree with that. So how do we stack up? Let's look at our report card. I'm going to thank Mandy Walker, who is the nurse who oversees our Code Blue effort here. She does a lot of the education, and she also collects all of the data rigorously. I'm going to show you 2013 and then 2014, which includes everything except December, because that data hasn't been crunched yet. Our number of codes, 87 in 2013, 76 plus a few in December in 2014. Our immediate survival is around 64%. That's pretty much on par. Survival to discharge, 24% in 2013, 19% in 2014. So we're stacking up pretty well compared to average hospitals compared to us. Neurologically intact survival, we had a pretty different spread, 20% in 2013, 14% this last year. Let's get a little bit more granular. This won't surprise any members of this audience, but the MICU service is sick, and there are a lot of codes that happen in NICU patients, which reflects how ill those patients really are. So every year, almost without fail, the MICU as a unit on 6 West has more codes than any other unit in the hospital. And the MICU service also has the most codes of any one particular service. This, of course, does not reflect the care being provided. This reflects how ill these patients are. In terms of our rhythm, I told you that asystole or PEA is about 82% nationally of the presenting rhythm, and we are right around there as well. Our survival by rhythm, there's a real big difference between 2013 and 14, but because these numbers are so small, 1 or 2 will make a huge difference. Our survival from BT and DF was pretty low in 2013, high here in 2014. Asystole and PEA, we did better both years than what the national average is, which is about 10 to 11%. So overall, I think that we actually stack up pretty well when compared to other hospitals that are similar to us in terms of our survival around Code Blue. So the summary for the epidemiology behind in-hospital arrest is that 200,000 of them approximately happen per year. The overall national survival rate is around 22%. We've not really seen much improvement in that since 2005. It's worse if you code at night or on the weekends. There's a lot of variability in the incidence and the survival depending on which hospital you're at, and we're doing pretty well at or slightly above the national median for comparable hospitals for the unadjusted rates. So now I'd like to move on to ACLS itself and try to dispel some of the myths about what we do when we're actually physically providing CPR and coding a patient and show you the evidence behind what you do. I hope that this will be elucidating, and some of you may have never seen this data before. So in 2010 was the last time that we had an updated algorithm. I'm going to quote my colleague and friend, Dr. Andrew D. Philippus, who says that no algorithm will ever replace a smart physician. And I agree with him completely there. However, we have this algorithm, and so we use it. And some of the things that were done by this committee was, instead of making it fully linear, we put this into a circle, not we, they. The purpose of this is to emphasize the continuous improvement of CPR that is recommended, and that high-quality CPR with minimal interruptions is really the most important thing that we do. We have a shock for shockable rhythms right here at the beginning of the algorithm, and then in the middle, as this most important part of the cycle is going on, we can think about drugs, consider an advanced airway, although that's no longer recommended as the first and foremost thing to do, and treat reversible causes. So what's the data behind all of this? It's a relatively young field, so I'm going to try to give you a historical tour as a whirlwind. Oh, before that, I'll talk to you about the major changes that have happened from 2005. So quality CPR, which we've always known is important, has really gotten a big push to go to the top of the list. And most important here is to minimize interruptions. You and I have all been at codes where people spend 30 seconds searching for the pulse, where is it, what's going on, looking at the rhythm, is it PEA, is it asystole, I'm not really sure, it doesn't matter. We have to minimize chest compression interruptions. And to emphasize how important circulation is, the old ABCs are out the window. It's now CAB. The reason for this is that people spent a lot of time trying to get airways in patients. I'm going to show you data about why that might not be as important. So circulation is now king. In my mind it always was, but now it's king. So we have circulation first, then airway and breathing. The ratio for two-person CPR is 30 compressions to 2 breaths now. And if you are a single rescuer, the recommendation is for hands only or compression only CPR. And I'm going to show you the data behind why we do that. Before I go into that, I will tell you that because of these recommendations, when I run a code, I select someone who's usually a med student or an intern, and their entire job is to be the pulse checker. So they have their hand on the pulse throughout the code. They know right where it is while the chest compressions are going on, so we don't waste any time searching for the right spot. And as soon as chest compressions cease and we're doing our rhythm check, if they don't feel a pulse, we're back on the chest within 3 to 5 seconds. And that's because of this data that I'll show you. Next, we emphasize defibrillation for shockable rhythms. I'll show you the data about why that's important to have that happen so early on. Devices and drugs have been de-emphasized. And then post-arrest care has always been important, but we're really trying to emphasize this now. In particular, we cardiologists love the early revascularization for ischemia as a cause, but we also now have recommendations about therapeutic temperature management. So let's go through some of this data. So in 1960, this was a landmark paper published in JAMA by Cohenhoven and Knickerbocker, who were surgeons at Hopkins. And prior to this, most people, if they got cardiac massage for their arrest, they got their sternum cracked and they got intracardiac massage or open chest. These guys, by doing, quote, rigorous studies on animals, 70 dogs, were able to show some good outcome for doing closed chest cardiac massage. This is the recommended position that they said in their paper. And I want to show you what they said, which is interesting because basically they foresaw the 2010 guidelines. First they said, pressure should be used to move the sternum 3 or 4 centimeters. Does anybody know what's the recommended depth of chest compressions currently? So greater than 2 inches. This is pretty darn close. Closed chest cardiac massage provides some ventilation of the lungs, and if there is only one person present in a case of arrest, attention should be concentrated on the massage. They had no data for this, they just said it, but I'm going to show you the data that proves they're right. And then this is the physiologic data that they were able to show the blood pressure that could be achieved during closed chest cardiac massage in an adult. These are pretty good chest compressions, got up to 80. This is their summary statement, which I love because it's very surgical sounding. Cardiac resuscitation after cardiac arrest, or VF, has been limited by the need for open thoracotomy and direct cardiac massage as a result of exhaustive animal experimentation. I told you it was like 70 dogs. The method of external transthoracic cardiac massage has been developed. Immediate resuscitation measures can now be initiated. And then at the bottom they say, well, first of all, their survival rate was 70% of their 20 patients, which I find impressive. But here's what they say. Anyone, anywhere, can now initiate cardiac resuscitative procedures. All that is needed are 2 hands. It's very simple, so they say. So this was sort of a landmark article. Well, this field has started by doing experiments in animals and then trying to go into the human world. So we knew that we could do this, but we had no idea how we should perform this closed chest cardiac massage. So in this study of dogs, they put them into cardiac arrest and then compared 120 compressions per minute versus 60 compressions per minute. You'll agree with me that the survival difference is impressive. From this, we then were able to look in humans and determine that the optimum rate should be greater than 100 beats per minute. Now I've told you a little bit about minimally interrupted cardiac resuscitation. Here's where some of this data comes from. So this is a really interesting study where an entire EMS system in one city was doing sort of the normal ACLS algorithm. So chest compressions, pulse checks, rhythm checks, which have inherently a lot of interruptions built into them. And then they retrained all of the EMS in their city to do a minimally interrupted regimen. And what that looked like will sound familiar to you. 200 compressions, aka 2 cycles, for 2 minutes of CPR, shock if it was shockable, and then immediately 200 more chest compressions. That sounds a lot like the 2010 guidelines. So they were then compared the historic data from the regular ACLS to the new data. The numbers are pretty small, 218 patients before the training, 668 after the training, but what you can see here is that there was a difference in survival from 1.8% up to 5.4%. That's just discharge from the hospital. And VF, which is our probably most treatable rhythm, survival went from 4.7% up to 17.6%. That's pretty good data to suggest that we should not interrupt our chest compressions. To switch and talk a little bit about ventilation during CPR. So I like to call this the overzealous respirator. How many of you have been at a code and you're watching whoever's at the top of the bed bagging, They're feeling the epi that's in the room, and so they're bagging like this. They're so excited, get that air in, right? I'm going to show you the physiology about why that's actually harmful, and why one of the things I do as a code leader is I gently but firmly remind them, please do not respirate at 60 per minute. So in this study, first of all, they observed people performing CPR, and they calculated the average respiratory rate provided. It was 30. Now, despite what all of the hospital charts tell you, I can tell you that 20 is not a normal number of breaths per minute for us. You and I breathe probably around 12 times per minute. So what happens when you deliver a positive pressure ventilation to someone in the thoracic cavity? You raise their intrathoracic pressure acutely. As you raise that intrathoracic pressure, you decrease venous return. You also decrease your diastolic blood pressure, and therefore you actually impair coronary perfusion. And one of the main purposes of CPR is to perfuse the coronary. We're really worried about perfusing heart and brain when we give chest compressions. So the thought that you might decrease coronary perfusion is actually harmful. So here is this data. This is from dog models. So here they tested different types of how many breaths per minute should we give. We're looking at millimeters of mercury, and we're looking at the measured intrathoracic pressure. So this is with 90 compressions per minute and 11 breaths per minute. The compressions give you this small increase and then small decrease in the intrathoracic pressure, and the breaths give you a large increase, but it's short-lived. So you can see that the pressure that this thoracic cavity is seeing is on average around atmospheric pressure, which is what you or I live at, and that's a good thing. If then I call the overzealous respirator to come and join us and get 47 breaths per minute, look at what happens. This person or dog spends the majority of their time with an intrathoracic pressure of around 20 or 30. Similarly, the 38 breaths per minute or 34 breaths per minute, we're spending a lot of time with very high intrathoracic pressures. Now, what about the slow and cautious respirator who delivers the breath slowly? Well, that's also harmful, because you see here, if I only give 11 breaths per minute, but I take 4 seconds for each breath, I still deliver positive pressure, and this is only a scale of 10 millimeters, but I'm still keeping my intrathoracic pressure high. They also, in this study, measured minimal intrathoracic pressure and coronary perfusion pressure directly at 12, 20, or 30 breaths per minute. What you see is the intrathoracic pressure rises as you increase your number of respirations, and your coronary perfusion pressure drops. This is the basis of why we don't want people to do overzealous respirating during a code. And you might hear me say, if you ever go to one with me, please give a breath every time that you take a breath. So to go back to our chest compressions and why respiration can be eliminated completely if you're a single rescuer. This was a study in the New England Journal, and this was very interesting. So this is for out-of-hospital arrest, bystander witnessed, somebody calls 911, and EMS is going to tell them what to do. So one arm of the study, EMS tells them to do chest compressions and mouth-to-mouth, single rescuer. Second arm, they tell them to do only chest compressions with no mouth-to-mouth. Then they look at hard outcomes. Smallish study, but this is the size of most of our resuscitation studies. It's about 250 per arm. So if you can see, discharged alive from the hospital, if we use mouth-to-mouth, it's 4%. Compressions alone, 14%. It's not statistically significant, but it's not different, and there's a trend towards better if you do hands-only CPR. In terms of surviving just to get admitted to the hospital, also a trend towards better with chest compressions alone, but not statistically significant. So based on this, we get that recommendation that if you are a single rescuer, either in the field or you're the only one there at the bedside at first, just give chest compressions and don't worry about the respirations initially until you get someone else there. So my summary of quality CPR, I hope I've convinced you how important this is. Adequate rate, greater than 100. Anybody know the song that you're supposed to sing in your head?
Staying alive.
Staying alive. Staying alive. Ah, ah, ah. That's what we do, okay? That's the appropriate rate. I didn't show you the data, but depth is very important because we want to compress the heart between the spine and the sternum and then allow enough recoil so that we can actually fill the heart and perfuse. Minimize interruptions. So even when your defibrillator is charging, you should be back on the chest doing chest compressions. There's no need to wait. And a good code, in my opinion, you really don't have interruptions more than a few seconds at a time. Do not hyperventilate, and also don't hyperventilate your patients. Perfusion is king, so we here have circulation before airway or breathing. Now I'm going to move on to early defibrillation and why this is so important. Back to some history. history. You may have heard of this guy, Dr. Zoll, because there's a whole company that makes things based on his work. He was the first American physician to describe using external cardioversion or external defibrillation. People have been also doing this when they crack the sternum and massage the heart, and they could take the paddles and do the whole thing. He and then simultaneously a guy in Russia described first applying external defibrillation. This is his first one, which I think looks like a record player. And I'm sorry the resolution is poor, but this is from his original article in New England Journal in 1956, where he showed that he was able to terminate VF by giving 360 volts. We don't really know what happened out here, but at least we know he terminated VF. A lot of data has looked at early defibrillation in the out-of-hospital arrest world for shockable rhythms, VT and VF. And this is a nice summary of a lot of that data. So looking at survival at 1 month, this is time to defibrillation in minutes. Look here, if I wait from 2 minutes to 4 minutes in order to defibrillate, my survival goes from 50 to 25%. That is a huge reduction in survival from a simple 2-minute delay. This is a somewhat famous study, although you may have never read it, but you've probably heard what it said. So this guy took the data from out-of-hospital arrests in 2 different counties and made a model based on how long it took you to get CPR and how long it took you to get defibrillated. Then applied that model to the second set in order to validate it. So basically here we see the time from collapse to CPR and the time from collapse to defibrillation. So if you get early intervention, CPR within 5 minutes, defibrillation within 10 minutes, 37% survival. Not fantastic, but still pretty good. If you wait more than 5 minutes for CPR, more than 10 minutes to get defibrillated, nada, 0% survival. So based on this model is where you may have heard this statement. There is a decrease in survival by 8 to 10% for every minute that you delay after collapse to defibrillation. Every minute, 10% delay. I hope I'm driving home the point here. So what about the in-hospital world? Because surely we can defibrillate people faster because we have a ZOL or a defibrillator on almost every floor within the hospital. So we should be pretty good at getting this done. So this was a study looking at the registry before it was called Get With The Guidelines. 7,000 patients with VF or pulsus VT. We did pretty good. Median time to defibrillation, 1 minute. Not bad. However, 30% of the patients had a delay defined as greater than 2 minutes. The factors associated with delay were black race, a non-cardiac admitting diagnosis, not surprising because people aren't necessarily thinking that they have VT or VF, a non-monitored unit where we can't see it happen in front of our eyes, smaller hospitals, and after hours. If we look at how survival was impacted by this delay, early defibrillation, less than 2 minutes, versus late, greater than 2 minutes. Early defibrillation, about 40% survival to discharge, 22% if you just waited greater than 2 minutes. That is statistically significant. And in terms of neurologic outcomes, 50% had good neurologic outcome in early defibrillation versus 50% of survivors in the delay. So even in the hospital, there's still improvement that we could make in defibrillating someone. And then they took this data and put a nice little stepwise graph for us here, showing that if you got defibrillated at 1 versus 2 versus 3 minutes, your survival decreases in a stepwise fashion for every minute that you delay. So there is no time like the present to shock someone. I will also give you my anecdotal thoughts, which are, in our patient population, a lot of them get the pads put front and side. The vector of energy goes between those two pads, and in a lot of our patients, all that we're shocking is adipose tissue. So I am very keen on when you roll the patient to put the board under them for CPR, slap the pad on their back, because then your vector for defibrillation goes straight through, and it's probably more likely to be effective. So the data behind early defibrillation, it must be immediate for a shockable rhythm, do not delay. The algorithm, what they recommend, based on the data that I've shown you, is that you actually give 2 shocks with 2 minutes of CPR in between before you even go to drug therapy for shockable rhythms. And I'm going to show you why, because the data for drugs is abysmal. For every minute delay, there's a survival decrease by about 10%. So now we go on to drugs. And here's where some of the fiction comes in. A lot of us get stuck when we're doing this, running a code, being very dogmatic about the drugs and the epi and the atropine and what should we be doing next. But I want to show you why your energy is much better spent ensuring good chest compressions, preventing someone from hyperventilating the patient and shocking them, than in worrying so much about the drug algorithm, because none of this data is good. This study comes from 2009 from the Norwegians, and they were looking at the administration of drugs for out-of-hospital arrest. So they randomized from their EMS, half of the patients would get ACLS with the drug algorithms according to 2005. And the other half would get just the chest compressions and the shocks and no drugs whatsoever. And they looked at outcomes. So basically, for return of circulation, no surprise, the drugs do better. 40% of the patients got their circulation back versus 25%. We know this. The drugs bring you back to life, but does it really matter? Survival to discharge, 10.5 versus 9.2, no difference. CPC is how we categorize neurologic disability. A CPC of 1 is good. So good neurologic outcome at discharge, 9 versus 7%, and 1-year survival. None of these have any statistical difference. So giving no drugs at all it did was make sure that you didn't make it into the hospital, but it didn't matter at all. The drugs bring you back to life, and they kill you 2 days later. That's for all drugs within the algorithm. So now let's look at a few of our favorites. Epinephrine, everybody loves it. So this is the only randomized controlled trial of epinephrine in the setting of cardiac arrest. The data in this field is not great. This is for out-of-hospital arrest, and these guys in Perth, Western Australia, randomized their out-of-hospital arrest to placebo versus epi. They had about 250 or so in each arm. I will say that the goal sample size here was a lot larger. It was stopped early because the EMS felt that they weren't providing the standard of care, and so several of them withdrew from the study. But I'm going to show you why that wasn't the case. So here, if we're looking at placebo versus epi, return of circulation, epi did better, 23% versus 8. But again, when you look at survival to discharge or good neurologic outcome at survival to discharge, epi was 4% survival versus 2, not statistically significant. In terms of neuro outcomes, epi is worse. And if you think about it, and if you know some of the data behind epi, what epi does that helps us during a code is alpha agony, which helps us to improve coronary circulation. But you get all of the other dirty side effects of epi, which include increased afterload. It's causing the heart to work harder with contractility and inotropy. And if you look at what it does to the brain, there is some evidence to suggest that epi decreases the microcirculation because of that vasoconstriction and actually worsens your cerebral perfusion. So there are a lot of downsides to epi. This is an in-hospital arrest study where they retrospectively looked at prospectively collected data. I really like this one. So they basically took codes in the hospital, and then they looked at how frequently you gave epi. Does anybody know the current recommendation for how often you can give epi? It's every 3 minutes is set. But do you know what happens? Every cycle of CPR should be 2 minutes. People get epi every cycle because we just want to do something, right? So here we looked at the difference between dosing epi, 9 to 10 minutes between dose, 1 to 3 minutes between dose, and everything in between. There is a trend to improve survival if you wait and give epi less frequently. So the authors here concluded that less frequent average epi dosing than recommended was associated with improved survival. I find this really fascinating. Everybody's favorite, amiodarone. Basically, the only study we have that's controlled for amiodarone was an out-of-hospital arrest study for all comers who had VF at any point during their code. What we see is that people who got amio survived better to the hospital than those who did not, but we have no data about how it impacts your survival to discharge or your neurologic status. It's my favorite drug, so I'm sad to tell you this, but that's the data behind amio. And then a few minutes on a recent study which has gotten some attention. So the Greeks decided that they wanted to try a totally new combination of drugs in the setting of in-hospital cardiac arrest, where it's witnessed and we know exactly what's going on. So they randomized patients to receive either the standard of care or this new regimen. And these are for patients that didn't come right back after a shock. So they needed vasopressors at some point. So you either got your epi, or you got VSE, vasopressin, steroids, and epi. So in the first 5 times that you pushed epi, you could give 1 milligram of epi, 20 units of vasopressin, and you gave 40 mg of methylpred the first round of CPR. If you needed pressors after you came back, then you also got stress dose hydrocortisone in the study group. The non-study group just got epi, and then normal vasopressors here. So basically, they did show improved survival in their intervention group, 13.9% versus 5.1% in the control group. And if you look at the people who went on to be in shock after they got resuscitated and got the stress dose steroids, that in size of impact is even greater, 21% versus 8%. But none of you have seen anybody giving vasopressin and steroids during the code, and I'm going to tell you my opinions about what are some of the problems with this study. Let me go back and show you. It's a small study, 130 in each arm, so very few patients. These were not statistically significant differences in the baseline characteristics, but with such small numbers, this could have a clinical impact. In the intervention group, 10% more of them had hypotension listed as the cause of their arrest. We know that vasopressin and steroids are good for hypotension, so maybe these people were more likely to respond to that therapy. Also, 10% less of them had asystole as the first rhythm, and I've shown you the huge difference in survival when asystole versus VT or VF is your rhythm. There was more epi given in the control arm. I've showed you some data about why that may have impacted outcomes. I also questioned whether the group that got the intervention had actually better chest compressions, because if you look at the map during the code, 75 in the intervention versus 50. That to me says that these people got much better chest compressions, but that difference persists even after the code. So maybe the vasopressin and the steroids are doing something to the map. There were some off-protocol steroid uses in the control arm. And finally, most importantly, these were a lot of new interventions all thrown in at the same time, and we really don't know which of these had the most impact. Was it the vasopressin? Was it the methylpred? Was it the post-code steroids? We really don't understand why there's this trend towards improved survival. So we haven't seen this widely adopted, but stay tuned because I think there's going to be more interest in that. So the summary of drugs here is that epi improves your return of spontaneous circulation, but does not improve neurologically intact survival to discharge. Or as I like to say, epi brings you to life, but then it will kill you 2 days later. Amiodarone, no data for survival to discharge. This new regimen may improve survival, but we don't really know why or what. So basically, you should listen to what your mom always told you about staying away from drugs. Just focus your energy on chest compressions and defibrillation. Briefly, I'm going to talk about targeted temperature management. I have another disclosure to tell you, which is that I conspired with Mother Nature this morning to give you a taste of not-so-therapeutic hypothermia protocol on your way in. So a brief about this. In 2002, in the New England Journal, there were 2 landmark studies that both reported the same thing. I'm going to show you the larger of the 2 studies. The idea here is that if we actually cool the temperature, we can have some neurologically protective effect by decreasing the metabolic demands of the brain after an arrest. So patients in this study were witnessed VF or pulse VT. They got resuscitated rather early. They had return of spontaneous circulation. They were excluded if they responded to commands, so they had to be comatose afterwards. They were excluded if they were comatose prior to the cardiac arrest. And if they had refractory hypotension or hypoxemia, which we thought would be worse with the hypothermia, they were not included. They were randomized in the ER to normothermia or hypothermia, and this is a study of total 275 patients. What we saw here is that the hypothermia group had a 26% mortality reduction. The number needed to treat was 7 to prevent 1 death. Pretty good. When you look at neurologic outcome, the favorable neurologic outcome increased by 40% in the intervention arm. The number needed to treat was 6 to prevent 1 unfavorable neurologic outcome. Based on this and the other study that was 77 patients, targeted temperature management, which is the new term for it, the artist formerly known as therapeutic hypothermia, was written into the guidelines in 2010 as a class 1 indication for out-of-hospital witnessed VT or VF arrest. Now, this is how we do it here at university or at Jewish. This is the Arctic Sun machine. It's gel-type pads that get wrapped around the patient for external cooling. Now, what about in the in-hospital arrest? So the guidelines give a 2A recommendation for in-hospital VT or VF because we don't have the data for in-hospital arrest, but we extrapolate that if you arrest in the same fashion in the hospital, probably it's still going to be useful. So what are people actually doing since 2002 when this study came out? So here is the percentage of in-hospital arrests that get put onto targeted temperature management in 2003 versus 2009. Study increase, look at the numbers. This is 0.5%. This is 3% of all patients who arrest in the hospital get put onto hypothermia. That's in contrast to 24% of patients in the hospital having VT or VF as their rhythm. So we're missing some people here that we could be doing this for. We're not doing it often, and we're not doing it well. 44% of these patients did not reach target temperature, and 17% of them were overcooled, both of which are bad to do in terms of neurologic outcomes. But there is an increased likelihood of initiating TTM in the young, people who didn't have a lot of comorbidities to begin with, so they were not in the ICU when they coded, if it was a weekday and you were at a teaching hospital. How do we do here at university? In 2013 and 2014, exactly 0 patients were initiated on target temperature management in the inpatient setting. Often this happens because we don't get called until 6 hours after the arrest happened. So if you are around and if there is a code that we happen to not be at as a CCO team, and you think that they might be a candidate for this, please call us no matter the time of the day or night, and the sooner the better, because we would be very interested in initiating this therapy in appropriate candidates. I won't show you the data, but in terms of PEA and asystole, the only data for TTM in those patients is retrospective and non-controlled data that suggests a trend towards possible improvement. So the way that most of us approach it, it's a 2B indication in the guidelines, meaning you can think about it, you can consider it. So many of us will say if they had short downtime, if they don't have other reasons why we might not want to put them on hypothermia, your brain doesn't really care why it didn't see blood, whether it was VT or asystole. The reason why we studied this as VT and VF in the outside the hospital world is because those patients are more likely to do better anyway. But if someone really has an asystole or PEA arrest that's witnessed in the hospital, short downtime, less comorbidities, we can consider it. So we'd be happy to talk with you about that as well. In the last very few minutes, I want to show you a little bit about what happens to trainees in the modern era, because this is an area of great interest for me. So this study, the main point here is that they looked at Mayo at the number of codes that they had and the number of codes that residents were going to. So in 2008, they had 3.8 codes per 1,000. That's the national average. When they took all of their intern schedules and then modeled to see how many codes on average does that mean an intern will see, it was 5 per year. This had decreased from 29 per year in 2002. The main reason for this decrease was because of the duty hours. These are 2003 duty hours, not 2011. And remember I showed you that graph about the variability in incidence of codes in the hospital. So if you have a hospital where you only have 2 codes per year, this number goes drastically down. And in 2015, this number also goes drastically down. So show of hands, interns in the room. How many of you have been at a true cardiac arrest where we're doing chest compressions during the last year? Just one. How many of you have seen one? Okay, so there's about 6 people that raised their hands. How many of you have seen 2? Good. Okay. 3. Nobody. So in 6 months' time, they've seen 2 codes. And in 6 months' time, they're going to be the one that responds to the code and is supposed to lead it. I find this frightening. Not for you guys, I'm sure you're not. So 2011, remember, we greatly reduced intern duty hours by 14. We took away 14 hours from what you used to do in your continuous duty. So this number of codes that they see is definitely less. It's still stressful. That's all the stuff they had to do. This is some data I collected last year. I was doing a different study, but I was studying residents over the course of 24-hour shifts. And I asked interns and residents, how many codes or rapid response did you respond to last night? The overwhelming majority of them said 0 in my study. Again, I find that frightening. This is in contrast to the fact that if you look at major teaching hospitals, this right here, physician trainee as the one who runs the code is 90% of the time. So I think that this is a little bit frightening. If you ask residents when they graduate from residency, do you feel pretty good? Do you feel pretty confident about running a code? They say no, 50% of the time. And 50% of them feel that how they currently get trained with ACLS is not sufficient to teach them what they need to be a code team leader. So, and this is also sad, that only 2% of them think that their time in the ICU teaches them anything at all about codes, which is really where the codes happen. So I think there's some room for improvement. Also, if you ask them, do you think you're good at this? They say, yeah, I think I'm pretty good. And then you test them in a simulation center, there's absolutely no correlation between their perception of their ability and their actual ability. So based on this data, the trend in current teaching is thinking about how do we teach people? Who do we teach? When do we teach them? In the simulation center, how do we do this appropriately and effectively? So the summary here is that there's a decreasing exposure of residents to arrest, probably less than 5 per year in intern season, then we ask them to run the codes the next year. Residents feel and are poorly prepared, and there's a wide variability in their exposure and in their skill sets. So where does that leave us for the future? So to go to the future, I go to my past. This is my mentor, Steve Schulman. I learned everything I know about running a code from watching him. And my life's goal is to teach everybody to be as good as he is at resuscitating people. Essentially, where this field currently is we know what to do. We have all the data that I just showed you. And all the data tells us about chest compressions and defibrillation, and ignore the drugs, essentially. Don't hyperventilate the patients. But there is so much variability in how this is being practiced in current hospital setting. So the field is looking at using simulation training in order to better train people as opposed to just sending them to ACLS class every 2 years. It's looking at interprofessional education. Why are we training nurses and doctors and respiratory therapists and pharmacists separate? Why can't we train them all together? There's a group of us here that are actually currently working on some educational and quality improvement endeavors ourselves, because the state of this science is at the implementation level. We know what to do, but we're not doing it. So how can we implement this at a wide level? And finally, in the survey looking at hospitals in this country, when they asked what are the barriers to getting better at doing in-hospital arrest, most people said there's at least one barrier. These black bars are major teaching hospitals like us. And the things that people said in major teaching hospitals is either there's inadequate training or the current institutional culture is not conducive to improving arrest. So I want to invite all of you to join me in making our culture one where we're willing to improve on this and willing to work together to get better outcomes for our patients. Now, I did train as an Oslerian, so I have to include a William Osler quote, otherwise they'll take away my diploma. Osler said, the greater the ignorance, the greater the dogmatism. This is so true when it comes to running arrest. The less that someone knows about the physiology and about the data I just showed you, the more dogmatic that they tend to be. This is just summarizing what Andrew G. Philippus said about no protocol replaces a good doctor. But instead of leaving you with Osler, I want to leave you with a demotivator. So this says adaptation. The bad news is that robots can do your job now, aka the algorithm. The good news is we're now hiring robot repair technicians. The worst news is we're working on robot fixing robots, and we do not anticipate any further good news. Please join me in not being a robot when it comes to treating these patients and to be smarter than the algorithm, but to know why it's there. Thank you.
That was outstanding. That was really, really good. First of all, I remember that article, and I think that with the ER article, and I think it was published in the New England Journal of Medicine. Yeah. But what's interesting about that article is that the authors were really pushing this idea that the community who was watching TV really had a higher impression, a very positive impression about what would happen to them if they got an arrest, which has implications of what decisions they make for their loved ones in the ICU or outside, what to do, and to be very aggressive about it. So I thought that was interesting. We used to love ER. I loved it because I loved medicine. My wife loved it because of Looney. So I have two questions for you. One, or comments, I guess. One, I just came back last week from visiting the Civil Rights Museum in Atlanta. And one of your comments there, you passed right over it, of how race impacts the way we introduce CPR. And that was interesting, where Black Americans were treated differently. And in fact, in the hypertension area, you show that youth or age was also an incredible variable. In this area where there's so much interest in health equality, how do we address that?
Yeah, I did glance right over that because I have no explanation and no suggestion other than that we apply these principles that we know about good CPR during resuscitation regardless of who the patient is or how old they are. I think that we do incorporate youth and comorbidities into, for example, how long we're willing to resuscitate someone. I certainly will incorporate that into my algorithm. In the pediatric world, it's unusual for them to stop a code before 60 minutes. Because they can have pretty good outcomes. My friend's a PICU nurse who told me that. I was shocked. For me, I usually don't go more than 30 if I haven't gotten any return to circulation, because my own suspicion about their neurologic outcomes becomes very poor at that time. I think that we take factors into consideration, but the race issue I have no explanation for, and I'm disappointed by that data, but I don't know what to do about it.
Questions? Let's start here, then we go over there.
Is there any data correlating this with rapid response teams and nurse blues? Because in non-ICU settings, dealing with people with comorbidities, it seems like arrest ought to be prevented. And the ones that occur, then you're going to have worse, you'll have worse numbers, but overall we'll have better numbers. That's the perception in the community.
Yeah. Here's the data. Thank you for asking that question.
And the paradox is if we do that well, your code response numbers are going to be worse, but overall outcomes will be better. That's our perception in the community, but I'm not aware of the data.
This is a meta-analysis looking at all the trials that were published after initiation of rapid response teams. And basically this is looking at the risk of your arrest occurring outside of an ICU, which goes down. However, your survival, no change at all. So what rapid response has done is shift our codes to happening in the ICU, which we all agree is better, but it hasn't actually changed mortality whatsoever.
So I saw the data about the interns' confidence handle CPA. So my question is, do you have any data about the third-year resident? Usually the co-team leader, how to monitor, supervise. How comfortable do you have any of those?
Oh, sorry. The data I showed you was from graduating residents. So when it was asked if they felt comfortable leading a code and if they felt prepared, 50% of them said no. That was from graduating senior residents in Canadian medical schools.
Can you go back to the slides and the Dr. Showman's?
I'm sorry, about which?
The last two. Okay, that picture you showed.
Oh.
Yes. Is the people?
This is staged.
This is correct.
This is staged. This is for a skit. That's an intern.
Here you have somebody who hasn't done a code
This is an intern being coded. This is all staged.
Bill, anything else? Go ahead.
Hi, thank you so much. That's such a great presentation. I really appreciate it. I just had two questions because I do think that we need to focus a lot on patient selection and on informed consent. And my concern that a lot of people are going to leave here, a lot of our trainees thinking, well, I'm going to counsel my patients, and 1 in 5 are going to survive an in-house hospital or in-hospital cardiac arrest. And I just wanted to find out from you what you think about the informed consent process, because I think that it's not done in an evidence-based fashion, and it's not really taught very well. We have evidence for that in medical schools, especially given that the New England Journal study that you quoted, they just looked at ICU arrest. They didn't look at anything that happened in the hospital in med-surg or ER, and they're in get with the guidelines hospitals, and patients that you're going to see are going to have the best outcomes to come in with cardiac arrest. In the setting of MI, history of CAD, and in the ICUs. Yeah. And then if you look at another study that looked at 26,000 survivors of in-hospital cardiac arrest, only 5% of them were alive in a year. And so I just worry that we're not going to do a good job patient selection, especially DMT, when you look at cancer patients and their outcomes. What about those subpopulations as well and their survival?
That's such a great point. I'm the first to say that I think the first question that should be asked as we're on our way into a room is, what's the code status of this patient, first and foremost, because we've all seen times where we resuscitated someone who was DNR, DNI, and had a bad outcome, which is harder for the patients and their families. But to speak to your point, a lot of us in the critical care world would say that when we start to allow patients to select, it's okay to do chest compressions, but I don't want to be intubated. That makes absolutely zero sense whatsoever. And I think you're right that we need to train people how to talk about this subject. But I see it, I guess I'm a pessimist, because I see this as this data telling me that it is very unlikely that we're going to get you back if and when you arrest. And I have no qualms about telling people that flat out when I'm talking to them about their code status, particularly in light of all their other comorbidities. And we also quite frequently are, for example, end-stage heart failure patients that are going to hospice. We're turning off their ICDs and all these kinds of things. But your point is very well taken that how we talk to people about this is probably colored by exactly what Dr. Roman said. The perception in the community is that, of course you can get me back, no problem, you just restart my heart. How simple is that? When the reality that all of us know is that it's a really gruesome, gory business to go through this code situation. And so how we talk to people about that's very important. Very well taken point.
And I would argue that our need to educate people better about end-of-life issues is equally important. I can't tell you how many times I go into an ICU patient and have this discussion. I get a very different answer than what my residents tell me. And when I ask them, did you discuss this with them? Yes, I did, but not at that length, not in that detail, not with that emphasis. And so that's very important. Let me go with it.
So, Lorrel, you said since 2005 there has been no improvement, right, in survival. So it just happens that when the resident hours change, start changing, and residents, as you pointed out, have less experience. I'm sure there is no study trying to correlate the two, but in your experience, is that a factor in the lack of improvement in the last 10 years?
Yeah, I can give you a little bit of roundabout data to support that. So when they compared, based on Medicare database, when they compared outcomes, mortality in the hospitalized world before and after 2003 duty hours, there was no improvement with the duty hour changes. So certainly it didn't make anything better. That's currently being looked at in a study to look at the 2011 rules. So we know that certainly things didn't get better with the duty hour changes. I kind of glanced over it, but in one of those slides, when you looked at hospitals that were what we call minor teaching hospitals, so those are places where you have residencies but no fellowship. In those places, you tend to have worse outcomes, and you less often have a trainee running the code. But the problem there is that you don't have like the senior fellows who might know what they're doing to make up for junior trainees that don't know what they're doing. So there is a difference based on what kind of trainees you have in your hospital. This is an area of great concern to me because my observational data, when I was a chief, one of my interns, there were sick patients at Hopkins, and one of my interns saw zero codes until she was in the middle of her junior year of residency, just because of when she happened to be on duty and not. And this really concerns me, so that's really the motivation behind why a lot of my educational programs are trying to aim at our lovely residents here and improving their outcomes in these low frequency but high stakes events. We're learning from the pediatric world where simulation is a huge part of how they train people. And there is a group that's been able to show in Chicago that by using simulation training, they not only improved resident performance in real world codes, or in simulation codes, but actually improved their performance in terms of adhering to guidelines in real world codes. So that's part of the emphasis of what our group here is looking at.
I trained back in the days when open cardiac massage was still being done, and it was the most dramatic thing that you could possibly see. But in my experience, I never saw a single person survive, even to get up into the ward again. I think was it really that bad? And I think it was. But it points out the tremendous difference just in the careers of a single physician of how we actually care about outcomes and care about data. My question then, so as an old person, the thing that struck me most was the de-emphasis of ventilation, because I grew up in the age of got to get those breaths in there. And I believe your data about survival. Are we as confident about neurologic survival without, with the deoxygenated blood? Your data only talked about survival.
Oh, period. Yeah. We are. I didn't show you that data, but we are. And there's also some physiologic data in animal models about how hyperoxia is probably bad for you in this situation because of oxidative damage, reactive oxygen species. In the MI world, we believe, and we even have some data to support that actually giving oxygen to people who aren't hypoxic is harmful. And there's some similar data being looked at in animal models in this arrest world. So there is some data looking at neurologic outcomes here. I just didn't show it to you.
So as someone who just recently took ACLS, it probably wasted a day and a half of my time. Would we not be better using simulation to practice CPR instead of doing this? The Heart Association seems to be fairly dogmatic on data where there's really no evidence.
I agree with you completely, and there is a trend and thinking about. So the former president of the AHA told me that there's a lot of interest in how we actually train and in people studying this rigorously. But I agree with you that simulation is really the way to go.
Last question.
Is chemical code only? That's a bad idea, isn't it?
Yeah. Based on the data I showed you, you might get them back, but you're just gonna kill them, and chemical code only. So I think that there are times when you are squirting a little vasopressin in because you're trying to keep someone alive because a family member is driving in from somewhere else, and you'll do things like that. But just giving drugs alone probably just kills people and actually brings them back. On that note, I'll say one thing to the residents. Don't waste your time on a central line, and don't waste your time on the airway, right? If that's going to interrupt your chest compressions, it's not worth it. And there's no way I'm going to do chest compressions so someone doesn't stab themselves while they're putting in a central line, and I'm not going to let you get stabbed either. So those things, based on the data I showed you, are not the right thing to be concentrating your efforts on during the code.
Thank you. Thank you, everyone. We're starting the year in not the best fashion. You've heard the news about Paris. You've heard the news about El Paso. You've heard the news about ISIS. You've heard her news about cardiac arrest. Focus on your circle of influence, continue good care of patients and of each other. Thank you.